Hello friends, this is another video. This time it's on chronic liver disease with certain complications, and I've used a actual case to kind of guide you through the management and diagnosis concerned in these patients of chronic liver disease, where things like hypertension, the use of fluids, how to assess fluid resuscitation, what vasopressors, and use of albumin, then the complications of coagulopathy where INR interpretation is so complex, and of course hepatic encephalopathy. So these are some of the things you'll be learning in this. It is not possible to cover everything because there are so many complications, but I will take you through these common complications, especially shock, the occurrence of hypotension, how to assess whether the patient needs fluids in these patients of liver disease with ascites and fluid overload state, yet they are having intravascular depletion, which vasopressor, norepinephrine, terlipressin, how much albumin, whether to give albumin, and so on and so forth. And tell you about coagulopathy in liver disease, hepatic encephalopathy. So to drink or not to drink is a big paradox. You don't drink, there's a problem. You drink, there's a problem. Now, this is our patient. So you can see the history. And we'll move on now. I think the history is quite clear and succinct, and a short history. So the differential diagnosis in this patient would be abdomen cancer. She's elderly, losing weight, right? CLD, because she's got pedal edema and she's got abdominal complaints, abdominal distension. CKD again, hypertension, elderly, pedal edema, and CHF again, pedal edema, hypertension, elderly, and of course there are rarer diagnoses. But please remember, common diagnosis first and rare diagnosis later. That's a dictum in medicine. So on examination in the ER, these are the findings, and the relevant is there's some degree of altered sensorium, and blood pressure seems to be pretty good. 140/80 is a good blood pressure for a patient who is not doing so well, and we have to realize sometimes these ER findings may not be correct. The vitals in the ER are very important because they are the first vitals, but please remember sometimes these vitals, especially blood pressure, is incorrect because the sisters who take them sometimes make errors. And there's some pedal edema and abdomen is distended. So again, the diagnosis, if you consider now, you have probably metabolic encephalopathy, or maybe there's a CVA, or she could be having metastasis to the brain or sepsis to explain the altered sensorium. So metabolic encephalopathy would probably be the first consideration here, as there are no focal findings which one would expect if there was a CVA or METs in the brain, and there's no real evidence for sepsis considering that there's no fever, blood pressure is good, and sepsis seems unlikely. So if you consider metabolic encephalopathy here, you would like to think of a CLD or CKD, right? And because abdomen seems to be quite distended, CLD seems much more likely. So these are some of the clinical diagnoses that we should consider in this patient, and such a patient is not so uncommon, especially for those of you who are going to be taking exams in medicine. So this patient gets admitted to the ward, and after 12 hours, the patient crashes. She crashes, and this is what happens. She's desaturating, blood pressure drops, she becomes unconscious, and she has had a melanotic stool. ABG is showing acute respiratory acidosis, lactate is high, ECG is gone into AF, and code blue is paged, and she shifted to the ICU after resuscitation, and she is intubated and put onto the mechanical ventilator. Labs are done at this stage. Hemoglobin is pretty good considering that she's got melena, and there's a mild elevation in INR. Kidney seems to be okay, but the ammonia is very high. Ammonia is very high, and LFTs are deranged. So we are looking at liver disease and hepatic encephalopathy in all probability, because this is very high ammonia. Mild elevations of ammonia can be seen in a lot of conditions, and especially if you don't take the sample properly and don't send the sample properly on ice, and it has to be processed in half an hour. So you can get a false elevation of ammonia, and there are other causes of mild elevation, but this is quite high. So in all probability, she has hepatic encephalopathy and probably chronic liver disease. Though when you get a patient who's got liver disease, do not assume that the patient has chronic liver disease. You have to make sure there is no acute liver disease, and the distinction should be clear. Sometimes there is acute liver disease, sometimes there is chronic liver disease, and sometimes there is an entity called acute or chronic liver disease or liver failure. We shall discuss this. So she's started on some fluids, NS and lactulose. Albumin is given, Lasix is also given, antibiotics are given because maybe she's got some sepsis, her blood pressure has dropped, we don't know, and GI bleed, you are supposed to give some sepsis, because after GI bleed there is hypoperfusion and there's bacterial translocation from the gut. And Rifa gut is started, that is rifaximin, and some dextrose for low sugars. NORAD is started for blood pressure, which is tapered over 48 hours and stopped. But the patient continues to be on the ventilator in altered sensorium, and her ABG actually is quite remarkable now in the sense that it shows significant respiratory alkalosis. So friends, respiratory alkalosis is a very important feature of hepatic encephalopathy. These patients hyperventilate and they get PCO2s in the range of 20, 22, 25, and as their hepatic encephalopathy improves, the hyperventilation decreases and the PCO2 starts rising. So that is a soft way of monitoring their hepatic encephalopathy, provided you rule out other factors which may be confounding the interpretation of the ABG. Now, radiological images here show that in the X-ray there is a pacing pad because she's just been resuscitated, and is grossly normal, but there is significant rotation, and when there is so much rotation it becomes a little difficult to interpret, and most of the times X-rays are rotated in the ICU. So you should know how to interpret the X-ray which is rotated and what are the findings which occur in a rotated X-ray which look abnormal but are because of rotation. We shall not discuss that here further because this is not an X-ray class. Then ultrasound shows chronic liver disease with ascites and portal hypertension. Now when you do an ultrasound, how do you know there is chronic liver disease or cirrhosis? So it's very common to see the radiologist writing coarse ecotexture and cirrhosis. That is wrong. Coarse ecotexture is not cirrhosis, period. Coarse ecotexture means what? It means either there is fatty infiltration or infiltration by something else. Right? So please, this is a wrong interpretation done by the radiologists many a time, and we think this is cirrhosis of chronic liver disease. What is suggestive is a nodular pattern seen on the ultrasound and supporting evidence with ascites and splenomegaly, and portal vein is actually supposed to be dilated, but its assessment on ultrasound can be fallacious, and if you get portal collaterals, that is suggestive of portal hypertension on ultrasound. And if you get a normal ultrasound, you can still have cirrhosis. So that is about ultrasound and cirrhosis on the liver, of the liver. And on CT, again, CT is a little better than ultrasound for diagnosing cirrhosis. CT can again be normal, but what you see in CT is the morphology of the liver. The caudate lobe is enlarged and there are certain other changes in the other lobes, and you will get evidence of portal hypertension on CT. And the liver will be nodular. Nodularity is very important. And nodularity comes from a certain amount of regeneration which is occurring in the setting of fibrosis of the liver. Fibrosis is synonymous with chronic liver disease and cirrhosis. And as you can see here in the CT, there are some dilated small bowel loops with air fluid levels. And the radiologist likes to report subacute intestinal obstruction. So, did this patient come with subacute intestinal obstruction? And she had deteriorated because of subacute intestinal obstruction? So, what are the causes of air fluid levels in such patients? So, friends, she is 56 years old. She is a chronic hypertensive patient. So, in all probability, she has some atherosclerosis of her mesenteric vessels. And when the blood pressure drops in these patients, there's hypoperfusion of the gut mucosa, and it leads to secondary ileus, something like a episode of non-occlusive mesenteric ischemia. So there's ileus, and because of that ileus, you get some fluid levels. And if this is bad, it can actually lead to a proper episode of non-occlusive mesenteric ischemia. So that is why probably she's got these fluid levels, and it is not really subacute intestinal obstruction. So the radiologist will report the way they see it, but the final call has to be taken by us because we know the clinical history. And the clinical history, the clinical scenario, the clinical picture is very important. So now it's kind of, I think, clear that she has chronic liver disease with hepatic encephalopathy. And the other concerns are she's got ascites, distended abdomen, and we do a tap. Tap is normal. She's in shock. She's got low urine output, and the ABG on the vent is showing respiratory alkalosis, which I just talked about, and lactate has decreased a little. This is at around 24 hours, and she's got a low GCS because she's in HE, and she undergoes a colonoscopy and upper GI, and there is some evidence of gastric varices. The hemoglobin has still not dropped, it is more or less the same, and there is a possible infection. So these are our concerns at this point in time, and now as we move on, we shall discuss all this and the treatment that was started, what is correct, what is not correct, what does the evidence say, what is the physiology, and what is the rationale. So that is the key message I'll be conveying to you. And apart from that, coagulopathy in liver disease, which is again an enema, and the other thing would be hepatic encephalopathy. So let's move on, my dear friends. This is the profile of a lapse over the next 10 days. And you can see the hemoglobin drops on day 3. So this is a characteristic feature of hemorrhage. When there is hemorrhage, the hemoglobin actually drops after 24 to 48 hours unless you give a lot of fluids on day 1 itself. Because when blood is lost from the blood vessels, the hemoglobin is not going to change unless you put water into that, or water moves in from the extravascular space into the intravascular space. So it's at 48 hours that the hemoglobin actually drops because she's got some fluids now, and there is some movement from extravascular to intravascular space. And blood is transfused to her because hemoglobin is dropping, and you would like to keep it at more than 7 generally. So 1 unit was transfused to her, and we can see creatinine goes up, and she's gone to renal failure, acute kidney injury, and ammonia drops over a period of time, and LFTs were abnormal, which also improved over a period of a week. So eventually what happens in this patient is that she improves over the next 10 days, and slowly she gets weaned off, and we are able to send her home. Now, before we move on, what are the definitions in liver disease? Because sometimes this is very confusing to some of our young friends. The diagnosis of cirrhosis, what is decompensated chronic liver disease, and what is the difference between cirrhosis and chronic liver disease, what is ACLF, that is acute on chronic liver failure, and what is acute liver failure. So these are some of the definitions in liver disease. So let us look at the definitions. So cirrhosis is actually a histopathological diagnosis characterized by fibrosis of the liver and its attendant complications, which you know. So cirrhosis actually is, no one does a biopsy, right? No, we don't really do a biopsy to diagnose cirrhosis. So cirrhosis is diagnosed when there is evidence of complications like portal hypertension with ascites, varices, deranged LFTs, and some clinical history like alcohol or hepatitis B, hepatitis C. So that's how you make a diagnosis of cirrhosis. But the answer actually is that there is fibrosis. So if you are asked what is the one test which will always confirm cirrhosis, it is actually liver biopsy. But we don't really do it and we don't need it. Then we come to decompensated chronic liver disease or decompensated cirrhosis. So decompensation means that the liver is actually gone into a extreme stage of chronic failure, and there is now ascites or episode of bleeding or chronic encephalopathy and jaundice. So you see, when the liver starts going into fibrosis, for a certain period of time, a few years, the liver is able to maintain its function and there is no real symptom. But once these symptoms start appearing, because the liver has deteriorated to such an extent that it cannot maintain its function, it is called decompensated chronic liver disease or cirrhosis. Chronic liver disease and cirrhosis is just about the same. The chronic liver disease probably you can call when fibrosis is just setting in. Once cirrhosis has occurred, there will always be fibrosis. And what is acute liver failure? Acute liver failure is simply encephalopathy and coagulopathy in a normal liver, and it occurs up to 24 weeks after onset of jaundice or the symptoms which are compatible with liver disease. Jaundice is almost always there right at the beginning or within a few days of onset of symptoms, and it can take anything from 0 to 24 weeks for liver to fail, right? So that is acute liver failure. So I think that the definitions are clear because this is a source of confusion to many of you. Now, what is this acute or chronic liver failure, which I did not describe, and which our patient actually has? So this is a controversial diagnosis in terms of its definitions, and definitions have been given by the Asia Pacific group, which I've just showed you here, by Sareen et al. From India, and there is a definition from United States, but this entity actually has been recognized by Jalal et al. From United Kingdom, and maximum work has come from there. So guidelines actually on chronic liver failure come from Europe and mainly from United Kingdom. So there is a lot of dispute on whether this entity actually exists also and the kind of definitions that have been propounded. But the best would be to remember the UK definition or the Indian definition, that is the Asia Pacific, depending on where you are studying and working. So this is the European definition, and you can see it actually means that there is organ failure in the setting of acutely decompensated cirrhosis. And the decompensation may be because of a hepatic factor or extra hepatic factor like the onset of sepsis or whatever is leading to deterioration of liver function. But there has to be organ failure. And the reason why Jalal et al. Propounded this definition or this subset was because when organ failure sets in these patients, they have a much worse prognosis as compared to just simple decompensation. So just to summarize the problems, our patient has shock, which is probably hemorrhagic or hypovolemic because there was a large melena, hemoglobin has dropped, she could be having septic shock, though it does not look like that, but these liver patients may not have too many symptoms because they're kind of immunosuppressed. Then there's acute kidney injury and there is hepatic encephalopathy. These three are defined as some of the organ failures in acute on chronic liver failure. And then there's decompensation because of upper GI bleed and ascites is there, and there is a possible infection. So these are the problems that we are having, and the first three are the ones which actually are included in the definition of organ failure for acute liver failure. So why is it chronic liver disease in the first place? I think that is clear. And why it is acute, that is also very clear, because she has deteriorated acutely, and why it is acute or chronic liver failure is also clear as per the definition, because there was acute decompensation due to the variceal bleed, because there was a large melena, and after that she has gone into different kinds of organ failure with kidney injury, hepatic encephalopathy, shock. So that is why she is called acute or chronic liver failure. And this is the Cliff SOFA score for ACLF. It's a modified SOFA score, and you kind of score this for the organ failure and then try to define how severe the injury or the degree of failure is, and you prognosticate, and you can kind of go ahead with a liver transplant. And the shading in light gray is organ damage, while dark gray is organ failure. And as you can see here, this is ACLF 1, 2, 3, depending on the organ score, and that actually prognosticates. So now we move on to the pathophysiology, and it is quite simple actually. There is cirrhosis, if you see, and then there's a precipitating factor which may be hepatic or extrahepatic, and because of that there is inflammation compounded in the liver, which leads to immune failure and systemic inflammation apart from liver inflammation, and there is organ failure, which is defined by a Cliff SOFA score or by a Apache score. So this is in a nutshell the pathophysiology, and then you try to intervene and modify the worsening of the patient's condition and stop the progression of injury. Now we shall move on to the detailed pathophysiology of these patients, moving on to the cardiac and the circulatory system, that is hypertension and shock in these patients of chronic liver disease or patients of chronic liver disease who go into this decompensated state or acute or chronic liver failure or shock or hypertension, whatever you may want to call it. The essence is how to manage hypertension or shock in these patients of CLD. So this entity which I've showed you here is cirrhotic cardiomyopathy. I'm sure many of you are not aware of this entity called cirrhotic cardiomyopathy. So what is this cirrhotic cardiomyopathy? It is a not well-defined entity in the sense there is no strict definition, but it is a very important concept, and as the degree of liver injury increases, it becomes more and more common. And the key features are there is either systolic or diastolic or both dysfunction, there is QT prolongation, and most importantly, when the liver is stressed, there is no increase in the cardiac output. What does that mean? That means wherever there is hypotension or fall in the circulating volume, the liver will always try to compensate by increasing the cardiac output. But in these patients who have cirrhosis and cardiac dysfunction, when there is hypotension, the heart fails to improve the cardiac output. The reason for that is not known. Maybe bilirubin and all these factors which accumulate and circulate in the system, reason is not known. So that is the essence of cirrhotic cardiomyopathy, and that is the dysfunction that these patients have. The heart is not good in these patients. And then you can have isolated pulmonary hypertension and RV failure because of that. RV failure can be because of cardiomyopathy also involving the right ventricle. Then we all know chronic liver disease is a hyperdynamic state. What is hyperdynamic state? It is a state characterized by what I've shown you here on the right. And why does this occur? This occurs because there is gross splanchnic vasodilatation because of release of nitric oxide from the portal circulation. And when there is a lot of nitric oxide being secreted, it leads to splanchnic vasodilatation, which leads to moving away of blood from the systemic circulation into the splanchnic vasculature. So the heart has to increase its cardiac output, and that is why there is a hyperdynamic circulation. And when the cardiac output increases, the SVR decreases, so the heart is able to work more easily and effectively. And tachycardia is always there, because if you have tachycardia, you'll obviously increase the cardiac output. So that is the hyperdynamic circulation of chronic liver disease, and that is the cirrhotic cardiomyopathy. So we always think of the liver and the bilirubin when we try to think of the state of the patient at the bedside, and we forget that the heart and the circulation are very important, and this is what is happening. And shock is something, which has to be dealt with. So to understand this is very important. That's why I put this up here and taken time to explain this. So this is just a picture to make it easy for you, and you can see on the left is the normal circulation. The red arrow shows the amount of blood in the systemic circulation, and the blue arrow shows in the splanchnic circulation. And on the right, you can see that the blood circulating in the splanchnic circulation has become much more, while in the red, the arrow shows the systemic circulation, which has become much less because of splanchnic vasodilatation. There is some degree of systemic vasodilatation also. It's not that there's only splanchnic vasodilatation. When nitric oxide is released because of chronic liver disease, there is vasodilatation in both the systemic as well as the splanchnic circulation. But the splanchnic circulation vasodilatation is very, very much more. Now, these patients of chronic liver disease have a low SVR, right? That means that the vessels are dilated, there is vasodilatation. So the vascular resistance, or the systemic vascular resistance, called SVR, is very low. It's really low. You must have seen also blood pressure in these chronic liver disease patients is often something like 80/50 or 90/60, and it doesn't pick up easily. Right? Yes. So you all seen that. So the other problem is that unlike septic shock, where again you have a low blood pressure, something like 90/60 or 80/50, these patients are in a volume overload state. They have a lot of ascites, they have peel edema, so there's already a lot of fluid in these patients. Unlike septic shock, where there's low blood pressure, but they are not in a fluid excessive state when they come to you. So you can give fluids to the patients with septic shock with some degree of comfort. But if you give fluids to these patients of chronic liver disease, when they don't need, it will actually lead to worsening of the overload state and worsening of the patient. So thereby, the hemodynamics and fluid assessment and fluid resuscitation in patients of chronic liver disease is of paramount importance. It's a very fine balance, more than septic shock. So let's move on. As the heart becomes full, what happens is it cannot pump out any more blood, right? So thereby, the systemic circulation, that is the aorta, the peripheral arteries, remain underfilled. And despite all your fluids and your vasopressors, which will act to some extent, there is hypertension. So that is the key pathophysiology of hypertension in chronic liver disease, which is distinct from septic shock. Now, coming to terlipressin and norepinephrine and vasopressin. These are the three vasopressors which are preferentially used and recommended in these patients, and we will talk about that soon. I'll show you a comparative slide. Uh, about assessing the volume status in critically ill patients with cirrhosis, there is no validated method. They don't apply the usual methods because of the different hemodynamics. The hemodynamics are different totally, as I told you, and thereby none of these methods apply. And what you can do is an echocardiography, or maybe you can do a PLR if there is not too much ascites and there is not too much cerebral edema, or you can see extremes of IVC if there is again not too much ascites and there is no pain. So, and they have the limitations, and you can go through this slide at your leisure. There is no proper way of assessing fluid responsiveness. Probably the best way would be in early stages when there's not much ascites and there's no cerebral edema, you can do a PLR. IVC would be very difficult, and IVC is not really a good way. And you can look at the echo and see whether the chambers are full or dilated, and of course there is cirrhotic cardiomyopathy at times. So just to show you in a more colorful fashion, flow track is one of the good ways, and you have to follow trends in cardiac output rather than absolute numbers, because the interpretation of flow track values depends on normal hemodynamics, which are not present in these patients. And you can use your PICO also. PICO would probably be the best, but you really don't use PICO in all the patients. And then again, echo, look at the chamber size, and if you can get a good view, look at the cardiac output by seeing the VTI. PPV and SPV are not validated in CLD. Please remember that. So assessment of fluid responsiveness is quite a tricky situation, and not really well validated. And this is to show you the comparison between the three vasopressors which are recommended for patients with CLD and hypertension. And for patients who go into shock, NORAD is the drug of choice, followed by vasopressin. Terlipressin is preferred in those patients where there is hepatorenal syndrome, because when there is systemic shock, is actually generalized vasodilatation, and of course there is more potosplanchnic vasodilatation, but when there is HRS, there is much more splanchnoportal vasodilatation, and terlipressin is very good at constricting the potosplanchnic circulation. That is why it is preferred and the drug of choice, the vasopressin of choice for HRS. And terlipressin compared to vasopressin causes much more ischemic events. That's why vasopressin is preferred in systemic shock or systemic hypotension. And terlipressin can also cause a little bit of decreased EF and a little bit of bradycardia, and it's costly. That's why it's kind of not so widely used, but definitely for HRS, it is the vasopressor of choice. So for shock, give NORAD and then give vasopressin. For HRS, give terlipressin. But you can also use NORAD for HRS, though it's not that effective. And the other differences are laid out. You can have a look at your leisure. So what kind of fluid should we give? If you remember, we had given normal saline to this patient, and you can give some normal saline, but if you are giving a lot of fluid, then you should give balanced salt solutions. Avoid hypotonic fluids because they can worsen cerebral edema and they are not good for resuscitation. And little bit of albumin can be used if after giving a significant amount of fluids you are still not able to maintain good perfusion. But we will talk about albumin shortly. So what is the management of shock or persistent hypotension in patients of chronic liver disease? So I put it up in a systematic fashion for you, and this is what I just told you. The map as such is not very well defined. What map you should target in CLD is not well defined because these patients have a low baseline map often. Yeah? They go around with a BP of 90/60 even, sometimes 80/60, they are well perfusing. So map is not well defined, but definitely should not be less than 60, I think. And the idea is that the patient should be perfusing well, urine output, mentation, lactate should be good. Though of course lactate is a confounding factor because the liver metabolizes lactate, and when there's liver dysfunction, lactate can be high. Though in cirrhosis per se, lactate is not high. In cirrhosis, unless there's decompensation, lactate is normally not high. It's normal. And dopamine is not to be recommended. That I think all of you know, unless there is bradycardia at the outset of shock. Dopamine is used in shock if there is bradycardia at the outset. Now coming to albumin, please remember that albumin is more of a drug rather than a volume expander. And these are the properties of albumin. It not only increases oncotic pressure, it is a transport medium, it is an antioxidant, it's an immunomodulator, it stabilizes the endothelium, and it has stabilizing effect on capillary permeability. So albumin is a very complex molecule, and even the formulations of albumin differ. The kind of albumin that you get in different packaging and different kind of concentration, 20%, 5%, are heterogeneous. So albumin remains a poorly understood molecule, and it's more of a drug rather than a volume expander, but there are definite indications. And there is no indication to give albumin in the setting of sepsis or bacterial infections other than SBP. And this was a study, a very well recognized study. There was some difference in creatinine, but no difference in survival. So these are the conditions, evidence-based, where you can give albumin: SBP, HRS, LVP, and maybe in septic shock as per sepsis 3 guidelines, or if there is persistent hypertension not picking up with fluid resuscitation. And on the right is a very recent study published in NEJM, which has again supported the statements I've given to you. Now coming to hepatic encephalopathy. Hepatic encephalopathy is an important complication and a very frequent complication. And if the patient goes onto the ventilator like our patient, you can't really extubate the patient till he or she is out of hepatic encephalopathy. So hepatic encephalopathy is primarily caused by ammonia, and this is the metabolism in health and in cirrhosis. So if you see here, ammonia is primarily produced in the gut, and from the gut, ammonia goes to the liver where it is converted to urea. Part of this ammonia is taken up by the muscles where it is converted to glutamine, and part of the ammonia is excreted by the kidneys in normal health. When the patient is in cirrhosis, the kidney does not excrete any ammonia. In fact, it goes back into the circulation, and actually kidney starts producing some ammonia. And muscle breaks down in cirrhosis. They have hardly any muscle mass, so again extraction by the muscles decreases. So all these factors lead to increase in the serum ammonia levels. And of course, the liver is diseased, so the urea formation decreases and ammonia increases. So this should be clear to all of you: ammonia metabolism. Kidney and muscle. We all know liver, but kidney and liver are also involved in the metabolism. Now, what is the pathophysiology of HE? We all know it's ammonia. Ammonia is the key molecule, and how it acts? It acts by getting into the astrocytes, where it leads to astrocyte swelling and thereby cerebral edema. But a small component is caused by increased cerebral blood flow. Increased cerebral blood flow. If you look at ammonia levels in patients with chronic hepatic encephalopathy, a small percentage, around 10 to 15%, right, have normal ammonia levels. And there is your increased cerebral blood flow and the other toxins which lead to hepatic encephalopathy. And this is the West Haven classification, which is, I think, kind of important to objectivize your findings. And it's a imprecise staging, stage 0, 1, 2, 3, 4, but this is the one which is generally followed. There is a sonic classification also, and you can also use the GCS. Now, when the patient goes into hepatic encephalopathy, there is normally a precipitating factor. Either there is acute deterioration in liver function because of some reason, or there are multiple other causes. He's taken some sleeping pill, or taken a high protein diet, or even something like constipation, hypokalemia, metabolic alkalosis, and so on and so forth. So these should be looked for and corrected. Sometimes there is no real identifying factor also, and the patient has gone into constipation which you don't realize, or there's a subclinical infection due to gut translocation, and this happens frequently. There's no identifying factor at times. Now the therapy for hepatic encephalopathy is, I think, quite simple and straightforward. Lactulose is one of the main drugs. You try to get 2 to 3 soft stools, and you can even add lactulose enema to your oral lactulose, add rifaximin, then zinc may be tried, and if there is bleeding, clean the bowel with a bowel wash. That always helps. And protein should be maintained at normal. There should no protein restriction. Otherwise the muscle breaks down and it further creates problems. And don't use any of these. But if there is refractory hepatic encephalopathy, then you can use albumin dialysis. So to tell you a little about ammonia, arterial ammonia is to be done, not venous. It is more accurate. And 10% of chronic HE has normal ammonia, and in ALF it is always elevated and it has prognostic value. And you can remove ammonia by dialysis. So dialysis should be instituted early, especially in patients of ALF. Not so much in patients of chronic encephalopathy or ACLF, but definitely in ALF. Now, coming to the last few slides, we all know that the INR is often sky high in these patients. INR can be anything like 4, 5, 6, and when you put in the needle, there is no bleed, right? You may have wondered why this happens. After all, INR of 5 or 6 is something where the patient is going to bleed. It happens all the time. In DIC, if the INR is 5 or 6, the patient bleeds. So we have to realize liver is the powerhouse for procoagulant and anticoagulant factors. And there is a delicate balance between procoagulant and anticoagulant factors in normal health, which maintains hemostasis. Now in liver disease, your INR goes up because the procoagulant factors decrease, as shown in this slide. But at the same time, your anticoagulant factors also decrease. So it balances out. Both decrease, right? Now, the INR actually picks up only those factors which promote bleeding, right? That is, your procoagulant factors are decreased, and the INR picks up only those factors which are 2, 7, 9, 10. That is why you get a high INR. But we have just talked about the anticoagulant factors which have also decreased, but these are not picked up by INR. The test is like that. The INR test was initially devised to check for warfarin effect, and warfarin actually works through 2, 7, 9, 10. So these are fallacies in INR and APTT, which we are realizing now, and now we are coming up with TEC and ROTEN, and we'll talk about that. So what should you do, about transfusion? So these are the guidelines, that if there is active bleeding, or if you're going to do a procedure and the platelets are anywhere like 30 to 50,000 and your fibrinogen is less than 100, then you should transfuse platelets or your cryoprecipitate. Cryoprecipitate is preferred to FFP for fibrinogen. And ideally you should be doing TEC and ROTEM if you have, because that gives you real time estimate of the clotting status. And this is a pictorial depiction of TEC, and you can see there is clotting being initiated, the clot being formed, and then fibrinolysis. And this is again a more detailed picture showing TEC on top and ROTEM below, and there is the clotting time initially, and then again the clot stabilization, and finally the clot lysis. And all these numbers actually translate into meaningful values telling you the status of coagulation. And TEC and ROTEM values cannot be interchanged because there is a slight difference in their methodology. And for those of you who are actually using TEC and ROTEM, you'll be able to realize what is meant by the slide. And for those who have not used TEC and ROTEM, I think it's not really worthwhile trying to understand this. It's only when you use TEC and ROTEM you can actually refer to this. But this is just to give you an idea. And this is again a simplified picture of what I just told you. And if you see here, this is very simple here. You can see this is your initial coagulation time here, and the clot formation here, and then this is the maximal amplitude of clot firmness, and then this is the time to lysis. So this is interpreted into numbers, and from there you get your estimate of what is wrong with your coagulation. And this is actually the future. Already people are using it, and it's recommended not only in liver disease, also in post-surgical bleeds and traumatic bleeds, where again there is a problem with the entire coagulation system. And these are some of the pictures you get in different situations of clotting instability in liver disease. So my friends, that was about it. And as you may have realized, I focused a lot on fluids and blood pressure because it is in a precarious balance, the fluid status in liver disease, because it's a volume overloaded state. There is a sea of fluid in which the patient is bathed, and if you do not manage this fluid status properly in hypotension shock, the ship is going to sink. I think this is probably the most delicate situation in all of critical care, where fluids have to be handled very carefully along with your vasopressors, much more than septic shock. And just like to tell you what we have done. We have tried to see how to assess fluid responsiveness, what are the parameters, and we are trying to understand the pathophysiology of hypotension, the difference from septic shock, the importance of nitric oxide and splanchnic vasodilatation. We have tried to understand cirrhotic cardiomyopathy, and then the role of terlipressin, vasopressin, and norepinephrine, what are the differences and where to use what, then where to give albumin, what is the evidence for albumin, and then we have talked about HE, and we have talked about ammonia, and finally a few words about your coagulation status and when to transfuse, when not to transfuse in your liver patients. So that is I think the end of this particular tutorial on chronic liver disease. And lastly, if you saw in the beginning, Lasix was given to this patient. You cannot give Lasix actually when the patient is in hypotension and is being resuscitated, and I think that was actually something we should avoid, because Lasix is not indicated in these patients at all. They already have perfusion, their circulating volume is less, so Lasix does not help unless the patient is a chronic patient, outpatient, where you give a combination of furosemide and aldactone. But in hypertension, you cannot give Lasix even if you are giving a lot of fluids and albumin. It is only going to cause harm. And some of the references, you can go through this. And lastly, there is no role of any extracorporeal liver support as of today. Trials are going on, but trials have gone on for a long time. There is no evidence. So don't try any extracorporeal liver support. And the answer to this question also, for those of you who may take exams, is nothing works in ACLF or even your ALF as of today. And anyway, we are not discussing ALF, so I will not talk about that.